This is the abdominal examination video. First, you will inspect.
So, I've already greeted my patient. I asked him if it was okay that I do the assessment of his abdomen, and I have washed my hands. And as you can see, his head of the bed is up slightly, maybe about 20 degrees. However, he could not tolerate it being at 0 degrees. So I want to point out that's a common mistake made in the final checkoff, is that students don't remember to put their patient at 0 degrees. So as we proceed, again, I'm inspecting the abdomen from the chest to the mons pubis. So my patient is actually already exposed. However, when you are draping your SP, if your SP had a gown on, you would want to drape the gown up to the bottom of the chest and use a draw sheet to drape the hips and provide for privacy. So as we proceed with inspection, again, I'm looking at the color, the contour. I'm looking for a distended abdomen, a concave abdomen, potentially discolorations, striae, moles, cancer. This is a 17-year-old male, so he actually has appropriate tanner staging, distribution of hair on the abdomen. If this was an older patient that potentially had liver disease, I could look for what I might think is ascites or potential fluid wave. So moving forward, before we begin our full assessment, I just want to review the anatomy of the stomach. Typically, we divide it into our assessment into 4 quadrants, starting at the umbilicus. But I want you to recall the ascending colon to the transverse colon to the descending colon. Remember, in your right upper quad, you want to recall that the liver, gallbladder, a portion of the gallbladder, and the head of the pancreas is there. Mid-abdomen, you're going to think probably more duodenal stomach. Left upper quad, you're going to think spleen. Left lower quad, you got sigmoid colon, female left ovary. Also you have ureters coming down here as well. The right lower quad, think appendicitis, right ovary in a female, and also ureters coming down. Mid-abdomen, think bladder, sometimes could be distended. And then of course you have your presentation of appendicitis, which we'll talk about that a little bit more in lecture. Sometimes we'll start periumbilical and then move to the right upper quadrant. So I want you to review your anatomy, which is actually some of the things I just talked about are on page 450. A lot of times when I approach an abdominal assessment, people say my stomach hurts, but I'll say to drill down on the abdomen, take one finger and show me where it hurts the most, and then I can visualize the organ, look at the concerning pathology view of that organ, and then I'll typically move forward with the collection of my HPI and my assessment from there.
So again, in review, inspection. Always obtain adequate exposure from the lower chest to the pubic symphysis. Always consider the surface anatomy and what organs lie beneath each area of the abdomen during inspection. Next, in the examination, we will auscultate for bowel sounds. You'll listen to a minimum of 2 different quadrants for 5 to 10 seconds in each area, remembering to listen long enough to actually hear and characterize vowel sounds. Although in your evaluation, you only need to listen to a minimum of 2 different quadrants, providers often listen to all 4 quadrants.
So the way I determined my 4 quadrants for auscultation, I basically drew a line through the impolite, a vertical and a horizontal line, and then that determined my 4 quads.
Next, percussion. You'll percuss for localized tympany or dullness, percussing in all 4 quadrants. Some providers can use the fingertip percussion method, but using a reflex hammer to percuss is perfectly fine. Next, palpation. First, you'll palpate lightly for tenderness, again examining in all 4 quadrants. Following the light palpation is a deep palpation, again assessing for tenderness. You'll examine all 4 quadrants using a 2-handed deep palpation technique. You always want to observe the patient's face during palpation. Don't be afraid to palpate deeply in the abdomen. You want to be able to comfortably palpate deeply enough to examine for masses or tenderness. Next, you will palpate the liver's edge. You begin palpating in the mid to lower abdomen, looking for the border of the liver. Then, you move your right hand, you move your left hand under the patient's right rib cage. Ask the patient to take and release deep breaths and feel for the liver during inspiration.
Big deep breath, please. Our patient is slightly ticklish. Okay, relax. Relax. Okay, so let's try it again. Go in, big breath, and relax.
Next, you want to palpate the spleen tip. It may be best to perform this exam from the patient's left side. Again, starting a bit low in the mid to lower abdomen, you want to begin to palpate. Working your way up, you want to place your left hand under the patient's left rib cage. Ask the patient to take and release deep breaths.
Big breath in. Out. One more. Okay, relax. Good.
First examine with the patient supine, then re-examine in the right lateral decubitus position.
Can you lay on your right side, please? Just roll over on your right side. Okay. Same thing. Okay.
Same procedure. Palpate in the mid to lower abdomen. Place your left hand under the patient's rib cage. Ask the patient to take and release deep breaths.
Deep breath in. Out. In. Out. Nice.
Return the patient to the supine position.
Practice.
Next, you examine for Murphy's sign. Use your left thumb or fingers of the right hand at the intersection of the costal margin and lateral border of the rectus muscle.
Deep.
You ask the patient to take a deep breath and move your examining hand superiorly. You're observing for cutoff inspiration.
Okay, big breath in. Okay, out. That is technically a positive Murphy sign because he halted inspiration when I palpated. Okay, relax. I know, it's okay.
Next, you'll examine for rebound tenderness. You'll examine both lower quadrants individually, pressing fingers in firmly and holding for 3 seconds. Quickly release fingers and observe for pain.
1,000, 2,000, 3,000, 1,000, up.
Remember to examine both
1,000,
lower
2,000,
quadrants.
3, 1,000, up.
Lastly, we're going to percuss over the costovertebral angle.
Could you sit up on me, please? Okay, so I'm just going to give you a little thump. Could you just catty corner for me? Thank you.
Remember to find the right location to test for CVA, tenderness, the costovertebral angle. It's okay to percuss over your other hand or directly on the patient's back using the fist percussion technique, using the ulnar side of your fist.
So, a couple of common mistakes that are made here. People want to come down low, but it's called costovertebral angle for a reason, because you want to find the angle of the ribs, and then you're going to put your hand there. You're looking for irritation or inflammation of the kidneys. And I'm going to give you a little thump on your back, okay? And then you're just going to go thump like that. And then you're going to find the rib cage on the other side. And a positive finding would be when upon hitting your fist against your hand, pretty much if the patient has pyelo or any type of nephritis, they're going to come up off of the table because it's going to be very tender when you do that.
This concludes the abdominal examination.